Welcome to the Equality, Diversity, Inclusion, and Health Psychology podcast. This episode, we're going to be focusing on a conversation with Kiran and Adam. They're both psychologists and in the concept of health and social psychology. So welcome to this episode. Kiran, I would like to ask you to introduce yourself to the audience.
Yeah, my name is Kiran Bains. I'm a practitioner health psychologist who works in a hospital and community setting. And I'm also co-lead of the EDI, the Divisional Health Psychology EDI task force. Over to you, Adam.
Hi, my name's Adam Jowett. I am an academic and social psychologist. I'm Associate Head of the School of Psychological, Social and Behavioural Sciences at Coventry University, where I was former course director for their MSc Health Psychology programme. And I'm also the new British Psychological Society chair of the Equality, Diversity and Inclusion Board.
Welcome to this episode, and thank you so much for your time, and hopefully you're going to give some interesting insights to our audience. So I think it'll be really useful to start with the first question, which is what we're focusing on. What do we mean by EDI, Equality, Diversity, Inclusion in health psychology? What does it mean for you, would you say? I don't know who wants to take that first. Adam, perhaps?
Yeah, it's a really good question. And I guess this is, my entrance into health psychology really started from an EDI perspective, really. So my PhD was looking at people's experiences of chronic illness from the perspective of being an LGBT person. And I guess one of the things that motivated me to go into that area was my own experience of being taught health psychology and the lack of diversity within that teaching. In fact, I remember, and I say this in my thesis, that when I was being taught health psychology, I found myself going through the index looking for terms like lesbian and gay and finding very few. And when I did find them, they were only ever in relation to sexual health or HIV. Other than that, you know, if you were looking at heart disease or any other kind of health issue, it was not spoke about in any kind of diverse way. So that's what led me into looking at EDI issues in relation to health psychology. So I think for me, it's about inclusion of difference and diversity, whether that be within the curriculum or whether that be in terms of considering diversity and inclusion when working with people in a health psychology practice, which I know Kiran's got a lot more experience of that than me. Maybe she can talk about that from that perspective.
Yeah, I mean, I've spoken a bit about my ideas around EDI before on this podcast, so I won't go too much into it, but I will talk a bit about how I got into it. I think I started to explore some of that stuff when I was an undergrad. I started to question certain things about, if you like, the invisible norms that I had been taught, particularly around heteronormativity, but also around racism and my experiences of racism and invisibility on the course. And then I did my master's in health psychology, and part of that was to do with wanting to look at health inequality and, you know, kind of really focus on that. And I found that there was a grand total of one lecture on ethnicity and health, which is completely inadequate. And then, and that didn't reflect my experience. I worked with people with learning disabilities, for example, and, you know, there's a whole lot, lots of things going on there around people with multiple long-term conditions and, you know, things like promoting health, but not really much strategy about how to do that. And then my doctorate, I focused on understanding and addressing health inequalities with people with learning disabilities, and looking at heterosexism, intersexism, and primary care, and then looking at diabetes. So that's kind of very much where I've kind of come from, and my thoughts have come from in terms of inclusion, but also the perspectives that we bring as people who are minoritized, and how that can look different based on the lenses that we hold. So that's kind of where I'm coming from with this topic.
They're both useful answers, and I'm sure the audience will find them very helpful. So thank you so much for that. So with this related question, and it might be a reflective question, so the concept is around still the importance of like EDI in health psychology. So if we are not considering people who come from diverse backgrounds, and if we're not making them inclusive in our policies, strategies, and our interventions, are we then as psychologists potentially causing more problems than actually creating solutions, for example? What do you think about that?
It's a really good point. And I think it comes back to what Kiran was saying about all of those kind of assumptions and norms that lie behind what we teach and the way that perhaps psychology is practiced. And I think it can be experienced as a form of exclusion. So, it's not just about not being included. Actually, that means that people are experiencing exclusion. And so I think it definitely can be a problem. And I think Kiran also kind of touched on this. I think as people who are working in this area, there's also the burden falls on us, I think, a lot of the time, to bring in that diversity and inclusion into what we're doing. So the responsibility is often on minoritized people to do this work, which I don't think should be the case. I mean, I had very similar experiences of, you get one lecture on something, if you're lucky. I don't, when I'm trying to bring EDI into the curriculum, I remember when I was teaching on health psychology, I was the person doing that one lecture on, sexuality and health. I do one lecture on the Doctorate of Clinical Psychology on sexual diversity. I've made a bit more of an impact on our undergraduate program. So I developed a whole module on gender and sexual diversity, but even then it's very much siloed as this is the lecture, or this is the module where you learn about these things, rather than being just usualized and kind of built within the curriculum, because it's always us doing the work. It's not everybody doing the work, which can feel quite frustrating.
Absolutely. And I found that very much in the academic context. In the practice context, it's interesting, we've started to really embed anti-racism into the work that we do. And and that can be really, really helpful because it's ongoing, and we really consider it with the people that we work with blood disorders, and primarily work with people with sickle cell disease, and they often bear the brunt of structural racism, and we also bring in intersectionality around sexuality and gender diversity, and I was reflecting on some of my positions in there, and partly because I do so much around this kind of work that I end up contributing that and taking on more because of that knowledge and because of that experience. So it's interesting, even when I'm the expectation isn't ostensibly on me, the expectation can be on me to contribute that additional, the additional work that I do, and that can be difficult to break out of. But it's one of the other things that concerns me about it, I think, for example, with the work that was, and Adam, you'll know more about this than I will, I'm sure, but one of the things about it being siloed and not considered in a health psychology context is that you can end up getting people splitting, you know, considerations of, okay, for example, when is my sexuality relevant and when is it not relevant when I go and seek out healthcare? And that can be a really difficult thing, because, you know, that means that people have to be experts in their own health, and they may not be, and that's not a reasonable expectation to have. So that, yeah, and again, that means siloed care, and that's not helpful. It also means that, I mean, and you know, I have experienced this where, you know, in work where I've been read by someone, and they were able to talk to me about, you know, who they were as a queer person of the global majority, and that was the first time they'd spoken to anyone about it. And that actually had a real impact on their health and their housing situation and things like that. I won't go into any more detail, but the point being that it was, you know, unconsciously, you know, it wasn't specifically thought of until that moment. And then I raised it as, do we all have our rainbow badges? You know, what does it look like to actually be meeting people's needs? What does it actually look like to be competent in supporting you know, LGBT plus people wherever they present with us, you know, and how can we build on that? And but again, that falls on me and my intersections around identity to you know, have that heard.
Do you think that health psychology exists as a discipline, as a concept, to address the problems caused by inequalities, and because it's not being equal, diverse, and inclusive? I'm just thinking, what's the point of the discipline? Think about the audience, and we're asking people to study this discipline because it's there to sort and solve or help or treat societal problems in terms of the health-related context. But if it's the cause is caused by inequalities, health inequalities, that's why we need health psychology to address these problems. So shouldn't it be that the case that the EDI agenda focus should be the thing that drives the discipline? That's what it's there to do. Like I said, I'm not saying that you have to agree or disagree. It's just,
I do agree. I mean, I'm probably co-leader of the EDI task force here, but I mean, you're preaching to converted maybe, but I do feel like it needs to be embedded in it, and it's difficult watching it not be, and watching, you know, for example, you know, being a lecturer and, you know, considerations around, say, BMI, and asking, well, you know, is this a BMI, like, you know, the study that looked at BMI in different countries and trends, did that adjust for different countries and the predispositions, or is this kind of, you know, what you've put here on the screen as this BMI is normal? Is this, you know, applied everywhere? Because we don't think it is, and I certainly know from my own, you know, ethnic background, it wouldn't be relevant to me. So, and I think there's some real discomfort there, you know, when I kind of, you know, indirectly questioned that. And, you know, the other thing is touching a bit on what you said earlier. Yes, we can cause harm by applying inappropriate frameworks and rendering things invisible, you know, with people, and we can actually perpetuate, you know, that by being, you know, treating everyone the same, or, you know, those kind of things, or, you know, not seeing things, you know, you know, that can actually be quite invalidating, and it doesn't help people to work with us or build trust with us, and it means that we might actually promote things that are not appropriate for the people that we work with. And it can also, that can have a knock-on effect on wider population as well. But yeah.
What do you think, Adam?
Yeah, I mean, I think it's a really good point that was made around, you know, this idea of when diversity is seen as relevant and when it's not seen as relevant. And I've certainly experienced when I've done ethics reviews, and sometimes they're not even planning to collect any data on, demographic data. And when I question it, sometimes they say, well, we're not collecting that data because it's not relevant. And it's like, well, if you never collect, if you never collect data on these things, then you wouldn't know that, there might be differences between these groups. Or so I think that can be really problematic. And like you said, both from a research context, to not gaining the evidence on health inequalities, and also in a practice context, and then in a from a patient perspective, the lived experience of having to make those decisions, as Kiran was saying about, is this relevant or is it not? Is it considered relevant? So yeah, I can't quite remember what the question was, but I kind of I probably went off on a tangent.
Oh no, that was still useful. I think you're right. I think the topic was around health psychology. The discipline is there to address these systematic issues around inequalities. That's why we have health psychology, I think. So therefore, EDI should be the central driver to the discipline, because if we consider the people who are doing it for ethically, like think about psychology, we learn about behavior to help them. Hopefully, that's what the standard should be. So therefore, the EDI should be the key driver to all of our, thought processes, decision making, and how you basically provide value to the discipline. That's why health psychology exists.
Yeah, and I think, I often bring it back to the the idea of the biopsychosocial model, which I think is a bit of a flawed model, or perhaps it's not. I think it's often more rhetorical than actually useful. But actually, I think a lot of health psychologists see themselves more biopsycho rather than biopsychosocial, because if you truly want to embed the social aspect in there, then you do need to embed diversity, and because these are the things, the social aspects of our lives that colour our experience of health and illness, that affect whether or our likelihood of becoming ill and how we live with illness. So I think if we truly do believe that health psychology should take a biopsychosocial approach, then yes, diversity is absolutely central to the whole endeavour.
I also think in some ways we to do wider services a disservice, if you like, because a lot of the barriers to actually receiving equitable healthcare are to do with things like resourcing, to do with early intervention, to do with, preventative care, and that means that people who receive specialist services end up having A, a siloed experience, and B, experiencing bottlenecks. But if we have, adequate resourcing for healthcare and early intervention, that doesn't just benefit them, that benefits the population around them as well, because some of this is to do with having a scarcity model of resources, and that is a choice. So it's just, and some of the, being able to advocate for people who experience marginalization in their healthcare, and push for better resourcing and better care, has that knock-on benefit for everyone. And some of it is also about again, inappropriate use of healthcare resources. So for example, in hospitals, young Black men are 9 times more likely to have a security guard at their bedside during a consultation at A&E. That obviously is not, what message does that convey? But also, is that a good use of security time if you're going to have that? I have my thoughts about having security in hospitals. But my point being that is unnecessarily intrusive, and where and for some things where I feel like we are involved in things, well, I do wonder if sometimes a simpler model of consent-based healthcare would actually be more appropriate. I am kind of thinking a little bit here of, you know, and I won't go into it too much, but, you know, the necessity for psychologists to be involved in trans people getting the healthcare that they need in specialist services. And at the same time, you know, some of the wider issues that happen that around, you know, people arguing about what's morally right or wrong, it means that you end up not tackling the other aspect of things, you know, difficult decisions that people may need to make. Say, for example, if they're taking hormones, you know, it would be really good to have an open conversation about what impact that has on your body without someone seizing upon it and saying, oh, this is why you shouldn't do it. You know, that it closes down certain conversations as well, which stores up problems for later.
I mean, historically, medical practices or health practices have not always been good or have not always been humane. We know that through history. And you know, it's okay for us to judge them in terms of like, oh my God, you know, they were engaging in such unhealthy practices and locking people up and all sorts, right? Giving all sorts of treatment to different people because they were not considering them as human beings, and they just saw them as experiments or lab rats. And I suppose in the case of the health EDI and health psychology, I don't want to be making the same historical mistakes again. That's why I'm bringing awareness, bringing a conversation, a debate, a discussion, a focusedness is so important, because I'm just thinking all those years ago, we need to learn something. And so we are aware not to treat people inhumane in today's like age or generation and practices. Because I'm sure in 100 years, they'll look back on us and say, I can't believe we did that to those people. Like we look back 100 years. And I covered that in my courses in foundation. And I'm teaching foundation health and sciences about the historical concepts of like unethical practices, and actually are we engaging them today in 2022. So it's not about the past, it's what we learned from the past, but what we're doing about it tomorrow, right now. So I just wanted to see if there was any thoughts around that.
Yeah, I think it's really important to engage with the, you know, challenging histories and the difficult histories that we have as a discipline, whether that be as health psychology or psychology more broadly, or healthcare more broadly. And that's certainly something I try to do in my teaching. But like you say, you've got to do that in a way that doesn't kind of present it as those were the bad old days and look, aren't we amazing now? But, you know, using that as a, you know, as a way to reflect on current practice and, you know, where we could improve, and like you say, also kind of bear in mind that we are stuck in our own historical context, but actually, you know, from a distance, when you're looking back, it might be seen quite differently.
Absolutely. I think we need to be reflective of that and reflective about what we know and how we know it. But I would also say maybe in some ways the challenges that we face as a discipline, you know, are probably a little bit different to now. I think that it's less, you know, I think people would say it would be less, if you like, consciously trying to subjugate certain groups of people based on their morality, although that sometimes does, you know, happen. It's inevitable that will sometimes happen, you know, based on you know, who we, you know, based on our morality, I guess. But I would say that one of the challenges that I see are more around indifference, invisibility, and you know, not being seen as relevant, and that can also have a damaging impact. I also think that sometimes we try to assimilate people into existing, you know, structures which aren't necessarily that helpful. you know, in terms of how we provide care. And I would say a good example maybe is looking at things very individualistically, you know, for everyone, when actually that might not necessarily be appropriate. And, you know, not looking at how people make, say, for example, social decisions around their healthcare, who they may be willing to interact with in healthcare systems, and, you know, at the same time with research, you know, and some of that, you know, some things are, you know, hopefully changing, you know, it'll be interesting to see how things like co-production take place, you know, and what does that look like, or community driven work, and how can we, you know, potentially work with that. But I think that would, I think those are some of the more the challenging aspects of what we're dealing with. And also sometimes, you know, silence around some of the social pressures that we face, the wider social pressures that we face, and how that does impact people, because, you know, we are living in really difficult times for a lot of people that will have an impact on their health, and that will particularly have a negative impact on those who are already marginalized. So how do we as health psychologists, you know, add our voice to try and improve equity? And that might mean expressing our, you know, the kind of principles that we go for. A lot of us, you know, are here to try and help and understand people, you know, but when it comes to advocating for that, you know, people find it difficult and challenging because they're not used to it. And we may need to really step up on that, because, you know, it can have serious consequences for them, and gradually also for us. We're not immune to that.
Well, yeah, I mean, it's the second part of the conversation. That was really useful, Kiran. Thank you very much. Which is kind of like second part of the conversation, and, you know, might be a bit shorter than the first part, which is all about solutions. So what do we think health psychology discipline can do to consider this concept of making it much more of an equal space for everybody, much more diverse, and much more, hopefully, creatively more inclusive?
That's a huge question.
Yeah, and that's why we've got a whole podcast on it, right? Because we have to answer this question in so many different ways. What do we think?
Adam, if you want to go first.
Yeah, I mean, it is a huge question. I mean, I guess I always kind of start by thinking about the curriculum, because I think, you know, if you want to change how people do research, how people practice, then changing how you train people, I think, is a useful first step. So I think looking at how diverse and inclusive our curriculums are, I think that can be quite difficult for people, because people don't necessarily see the lack of diversity, or you know, they don't know what they don't know. So I think, for instance, as you know, I think our professional bodies and can help with providing resources for that, because I think that's really useful to you know, show people this is how you can have a more diverse curriculum. This is how you can be more inclusive in your educational practices. So I think I would start there. But, you know, I mean, I just mentioned about professional bodies. I think professional bodies have got their own things that they need to do in terms of making sure that they're diverse themselves, and looking at their own policies and practices and structures, looking at why perhaps they're not as diverse as they could be, making sure that they reflect the discipline as it is. So I think there's a whole range of different things we can do, and as well as, you know, training, also evaluation as well. So evaluating how inclusive we're being, how diverse we are as a profession, as a professional body, or whatever it is, as a student group. You know, in all of those different ways, kind of doing evaluation of EDI, I think is useful. We've got to gather that evidence.
I would say that sometimes people find that the idea of changing things overwhelming. And I think I like that you focused on specific practical areas that, you know, people can look at. I would say that some of this is possibly grounded in the local, like in where you are, and, you know, the people that you come across, as well as, you know, some of the general guidelines that might be out there. I really like that, you know, for example, BPS Sexualities has guidelines on working with sexual relationship with gender diversity. That's really practical, and I think we need to have look at other, you know, additional, you know, forms of how intersectionality can look, and what it may look, you know, guidelines may look like, you know, around that as a starting point. I think that, you know, sometimes, you know, having done this work for a while, there's two things that I really find helpful, which is to kind of recognize patterns of where, you know, where dominance and where exclusion can, what it can look like, you know, because sometimes those patterns repeat themselves. And number two is understanding from other people's practices of how they've tackled things, and really connecting and supporting each other, you know, through like small networked approaches, can be really helpful for, you know, just learning, mutual learning and support, which I think is helpful when you're trying to change things, you know, systematically over time. So, and yes, and we do need to be aware of, you know, how different forms of, you know, marginalization can intersect and be multiplicative, if I can say that properly, with each other. So, you know, and what that might look like in a practical sense, you know, for example. So, and then think about, okay, you know, are there case studies of what can be helpful here, you know, to start off as a guide? Because I think there's a lot of people that want to make changes. I think that they feel at a loss about how they can make those changes, and also they're afraid of making mistakes, but making mistakes is part of being human. And as someone else once said to me, you know, it'd be surprising if you didn't, say, for example, imbue a little bit of structural racism when you live in a structurally racist society. I would say that that's very true of other forms of isms, heterosexism, cissexism, classism, ableism, just to name a few. So, you know, how can we kind of, you know, like reflect on that and how it might look like, and it does become easier over time.
I think also, you know, like you say, people are very open to wanting to create change, but they struggle to envisage what that might look like. And I think they often are kind of wanting almost a tick box kind of, you know, you need to do this, then you need to do that, and then thirdly, you need to do this. And that's not kind of how it works. It, you know, it's much more reflective, and that can also be quite overwhelming to not be given a this is what you need to do, but actually to be constantly reflecting about how we, you know, reflecting on everything that we do and how we do it and how things are structured, rather than just a kind of a tick sheet of once you've done this, you know, you're good to go.
Absolutely. And I think that's where we, you know, like I'm saying this as a practitioner, health psychologist, we often work with people who are struggling to cope with uncertainty and the worry that that creates. But we also need to acknowledge that you know, that being uncertain is part of the process. And if we are, you know, helping others to potentially, you know, cope with that, then we also need to think about how we cope with that ourselves. You know, and to try and build cultures which are, you know, learning based cultures, you know, well, compassionate cultures, which, you know, yes, are accountable for sure, rather than, you know, blame cultures, you know. So just those kind of things I think are important, you know, and how, you know, it's not just about, you know, participation, it's also about, you know, being really humanizing the process of wanting to do this, and see, you know, EDI, people who experience marginalization, for their humanity, because that's where a lot of, you know, problems do exist, you know, when people reduced to that tick box, or, you know, reduced to an exercise.
Fascinating discussion. That brings us to the end. We could go on, and hopefully gives us the audience some questions for them to think about. But we're not here to provide all of the answers. I think this is a process of getting involved in the debate and discussion. And if you have any comments or thoughts, then let us know. If you'd like to make a contribution, again, get in contact with us with the details that will follow in this series of podcasts that we're doing around EDI in health psychology. My name is Jalal. Thank you so much, Kiran and Adam, for your time. And we will hopefully catch up in a different space. See you next time.